loose, so we can. It's really meant to be a monthly get together to tell you a little bit about what VPCA's activities are going to be, really focused on the next month, and then some of the major events that we're doing, and then. If we've got if there's some congressional stuff that's going on, we usually take about 5 minutes to talk about our congressional efforts, and then at the end of that, we're starting to invite industry players to come and participate. And today we've got Dr. Matt Allaway from Perineologic, who will talk to us about that lovely subject we all go through of biopsies and what the best way to do those are. So right now we have the next events coming up in May is AUA. So we've been working hard. We're going to we have a booth there. It's number 263. Joe, I was going to ask while you're here on the line. I was going to ask if
somehow I lost you. It went muted for a second.
Yeah, I think Amy did that. She's probably been wanting to do that all day. Anyway, so I may we've got a couple of things coming up in DC later on in the year, but then also at AUA. I don't know what your schedule is, but it may be worth having you come down and helping us out a little bit. But we've got a booth there. We're actually launching formally launching our software that we've developed with Self-Care Catalyst. It's the prostate cancer health storyline software, and really it's intended. We know exactly what we have to do now to get it into the VA. We're talking to some VA physicians about being a sponsor is all we need right now as a sponsor. Then we can start going through the process of integrating it in there. Matt, I was going to talk to you as well as offered up to you. We'll send it versions out to you. It's for free to start with. Basically, it's a patient-centered software that runs on your phone or your computer, and it's really intended to help with really post procedures, but really gathering patient-reported outcomes in real time. And it also gives your office a dashboard, and you can put warnings on there that allow you to immediately talk to patients if something's not going right. It's got a telemedicine aspect to it, and it also helps. We're looking at a sort of the procedures, and we've got the CPT codes and things like that that are in there that actually help bring more revenue to a practice. And we've talked to a couple of the LUGPA players, and we're going to try to push on them to get it fielded. So we'll have some time. We'll definitely want you to come over and look at it from a practice perspective there. So we've got a lot of meetings set up to brief other urology practices on it, and also meeting with some VA people as well, and also some researchers from industry that could use it actually as they track patients going through that process of any kind of a clinical trial or clinical study. That's it. Other two big things. The November Veterans Day event in New York City is in planning. We've committed to the Intrepid. We're sorting out which Marriott hotel that we'll center ourselves in, and we've also we're in discussions. I think we're going to do it. Have a men's health day following the event. So Saturday morning we'll have a men's health day. We're talking to people like the fire department, the VFW, a couple of publications in New York City to actually help host that whole thing. And then let's see what else. We signed up for the Miramar Air Show in September. So what that's going to be is sort of a give back to all of our sponsors. The Marine Corps are expecting a very large crowd this year. They're saying that somewhere in the neighborhood of 800,000 to 1 million people in attendance over 3 days. So they're looking at about 300,000 people a day. Our chalet will be branded. It'll look like Prostate Cancer Central, and we're actually looking at leasing a couple of vehicles, mobile blood vans or blood mobiles, and doing PSA screening at the event. So we're talking to Wendy Poag and her people about coming out to help us out with that whole thing, because there'll be a lot of guys, a lot of people that need to have it done, and it'd be great to, great sort of a place to do it. We can get them in and get them out fairly quickly in a little blood van type of deal. So that's good. And front row seats in the chalet for the Blue Angels, the Red Arrows, and all the other air show airplanes that are going on. So it'll be a fun weekend. It'll be, and hopefully we'll get a lot of people to participate and have some fun there. We're also going to screen. We've decided at the VFW National Convention in July, and that will be again in conjunction with the Prostate Conditions Education Council. They have an award, or it's a grant through the University of Colorado and NIH to actually do this screening. They've done over 5 million PSA screenings in this program. And what happens is it gets sent back to, you take the screen, it gets sent, or the blood, it gets sent back to Colorado, and Dr. David Crawford is the one that signs off on all the levels, and they send back a letter to whoever gave a sample. If it's if it's above 3 nanograms per milligram, actually get on the phone and call the guys and tell them that they need to get in to see their doctor and to take the reading and the sample back with them. So it's a nice little program. We need to, I think, get more out of it. We need to exercise a little bit more. So we're going to try to do that. That's about it. I think on the legislative side, I didn't see Sarah sign in. But anyway, there's so HR 4880. I spoke with Congressman Dunn 2 weeks ago, and they're trying to get the Democrats to put it on the docket to vote on it. We're still pushing that. There's also another effort that just popped up. A bunch of former aviators, and I think Vince Alcazar and the people at the Red River Valley Fighter Pilots Association have been pushing this along to get some funding for the Air Force to do a study, and I think we're going to help them out if they get approval. That study, or our study, the one that we're in with Dr. Jeff Jones and Dr. Van Allen at Harvard, we'll all qualify. I mean, it would help us to fund the assays that are required to get the DNA samples and to put it all together. So that's those things are all good. There's all efforts in Capitol Hill. I think we're raising more awareness. We've got some guys that are dealing with it, so we'll keep supporting them, and we'll let you know how that goes. We actually had also a discussion with American Cancer Society. Pam Traxel is their sort of chief lobbyist in DC, and she's on board to help us with any of these ventures that we're looking at as well. So with that, I'm going to turn it over. I think I'd like to introduce Dr. Allaway. Dr. Matt Allaway has a practice in Maryland, and he's also the president of Perineologic, which is I'm not going to steal his thunder, but it's really the way, when we talk to guys about doing biopsies, it's really the way to that we ought to be thinking about them and actually moving these things forward. So we're helping them introduce this to a number of VA urologists and other personnel that are in the prostate cancer world. So with that, I'll turn it over to Dr. Allaway. Matt.
Thank you, Bing, and thank you very much for the opportunity to work with this fine organization. These grassroots efforts from patient support groups, this is really, really important, because the voice of men is not always heard when it comes to prostate cancer. Even though it's the most common cancer in American men, it doesn't always get the proper attention. Men don't always want to talk about their prostates. It's often their spouses or loved ones that wind up advocating for them. So to see this happening, we're all about this, and we will do whatever it takes to support this organization. It's very important to me. I have a quick little PowerPoint to kind of just go over, what we've done as a company and what the passion was behind it, what's happening, the future of prostate biopsies. Whoever's administrating the Zoom call, could you disable or could you enable the participant sharing screen, please? Perfect. So I'm Matt Allaway, as I've been introduced. I'm a urologist. I've been practicing for the last 20 years in Western Maryland. And I was very blessed because I had a very bad cancer when I was 20. It wasn't prostate cancer, but it was a GU cancer. It was a rare form of germ cell carcinoma. I was treated by urologists and I had 3 recurrences. I went through 9 cycles of chemotherapy, 3 major operations. I'm a statistic that's lucky to be alive. So my goal was to, be the best urologist I could, but also try to contribute something back to the system. I thought that my contribution would be in the arena of testicular or germ cell carcinomas, but it turned out that my biggest contribution to the field was the diagnosis of prostate cancer, because no matter how we frame the topic of screening for prostate cancer, you have to have tissue. You've got to get a piece of tissue from the prostate to make the diagnosis. We, of course, have fabulous imaging modalities like MRIs and PET scans, but at the end of the day, you've got to get a needle into the prostate and you've got to extract tissue. And as I was practicing urology, I realized that there were some major flaws with how we were making the diagnosis with our, current biopsy technique. But let's give you a little bit of background because I think it's kind of a great story. I mean, how did we biopsy people in the 1920s? And how did it evolve to what it is currently being the transrectal ultrasound guided biopsy? And where did Transperineal emerge from? Well, this is a schematic from an anatomical surgical textbook. And you can see that it's kind of a crude sketch, but there's an incision in the perineum. So we never thought of going through the rectum to get to the prostate. It was natural that you would want to go through the perineum or the taint. So an incision was made in the perineum and we literally dissected back to the prostate and would actually then cut a piece of the prostate tissue out. And while the patient was on the table, they would run it down to pathology, look under the slide, and if there was cancer, then the decision was made to either remove the whole prostate or part of the prostate. This was a pretty invasive way of diagnosing prostate cancer. Even if the patient didn't have cancer and you just closed them up, they were often in the hospital for up to 1 week after a biopsy. That's how it started, through the perineum with an incision. And that's when it all began in the early 1920s. Of course, the morbidity of making a big incision was not thought of as innovative enough. And so there were several urologists and general surgeons that tried to come up with other methodologies to extract tissue from the prostate. So there were all sorts of different needle devices. The popular one was the Vince Silverman cutting needle. And basically what you did was you still went through the perineum because it was the most logical approach to get to the prostate, but you couldn't see the prostate that you were biopsying. You had to put a finger in the rectum and feel the prostate and feel the hard lump or nodule, and then guide one of these specialized needles through the perineum. You could kind of feel the needle as it's gliding toward the prostate, and then you'd pierce the prostate and extract some tissue. Well, the problem with this technique, there were many. One was that your aim was terrible. I mean, you were just poking at the prostate, hoping you would get tissue that would make the diagnosis. The other problem is you often went through the perineum and wound up perforating the rectum and actually biopsying your finger in some cases. So they started to wear little like thimbles and things over their index finger when they introduced the actual needle, because it was harmful to both the surgeon and the patient. But this was the way that it was performed. Then everything changed basically in the 1980s. But in the 1970s, that's when ultrasound technology became a very realistic option. And what they were able to do was to design an ultrasound probe that you could slide into the rectum and see the prostate. For the first time, we could actually see the organ we were trying to sample. And they had to, modify the probe over, a period of about 10 years to make it actual prime time for urologists. But then in the mid 80s, the FDA, approved ultrasound technology for biopsying the prostate. And unfortunately, you weren't able to go through the perineum because they had no way of navigating a needle through the perineum with an ultrasound probe in the rectum. So the only way they could get the biopsy needle into the prostate was to slide the needle right alongside the ultrasound probe as they're looking at the prostate from the rectum, and then perforate the rectum to get into the prostate. And when we first started doing biopsies this way, we only took like 6 samples. And through the years, we realized that 6 wasn't enough. Then we moved to 8, then we moved to 10, then we moved to 12, then we moved to 14 and 16 in order to adequately sample the prostate. And in parallel with this advancement was the FDA approval of the PSA test, which actually became the first sort of blood-based tumor marker that we could screen men, because prior to the PSA, your diagnosis was made based on a rectal exam. So if you felt a lump or a hard area on the prostate, you suspected cancer and did a biopsy. Well, if you depend on the finger exam, by the time you diagnose the cancer, 85% of the patients already had prostate cancer that grew outside of the prostate. But now with PSA, we had a way of screening the population so that we could detect these men before we felt a lump or a nodule. And then it flipped the coin 180 degrees, so that now in the PSA era, thankfully, about 80% of men are now diagnosed with disease confined to the prostate, and only about 15 to 20% where things have either grown out of the capsule or actually left the prostate itself. So in the 80s, we decided that, yes, we're going to look at the prostate under ultrasound guidance, and we're going to guide a needle into the prostate through the rectum. But we knew that we were passing our needle through fecal material to get to the prostate. And we knew that was an issue. It was not a problem when we were poking needles through the perineum, but now that we're going through the rectum, we have to load these men with antibiotics. Otherwise, every patient would practically get infected, because we're actually injecting fecal material directly into the bloodstream via the prostate. So there are now represented 2 major problems with prostate biopsies. The first was infectious complications, because the antibiotics we started using in the 80s and the 90s were working fairly well, but with society's overuse of antibiotics, suddenly giving the patient a dose of a sulfa-antibiotic or a Cipro or a quinolone antibiotic suddenly wasn't working as well. And men were starting to get breakthrough infections, but not just burning and frequent urination, but actual sepsis, which means that the bacteria have entered the bloodstream, and the patient with sepsis has to be hospitalized, put on IV antibiotics, and their hospital stay can range from 2 days to a week. It could be on a med-surg floor. It might need ICU care. And about 12 to 15% of patients with sepsis will die of sepsis. So this became a huge problem. The other problem was that by going through the rectum, the trajectory of the biopsy needle is not in line with the entire prostate. So the entire anterior half, or the top half of the prostate, is very challenging to biopsy. And even when you do biopsy it, you're not obtaining a very good representative sample. You're basically poking up at that region of the prostate. So we realized that, unfortunately, many men were either having negative prostate biopsies when they still had cancer, or the cancer was misrepresented, meaning they were thought to have a slower growing prostate cancer, but they in turn had a more high-grade cancer that was of more risk. So these were the 2 problems that I faced about 7 years ago. And I decided, thinking through the problem myself, because I had 2 things happening. I had a growing population of men on active surveillance, and I knew that if I would continue to do transrectal biopsies, there was a high probability I was misclassifying the cancer. So I was telling men you have low risk cancer, but I was missing higher grade cancer somewhere else in the prostate that I couldn't easily sample with the transrectal approach. The second problem was men were getting infections and some were getting sepsis. So if you have a patient on active surveillance and you biopsy him and say, good news and bad news. Good news is you have slow growing prostate cancer. The bad news is you got a terrible infection. We're going to have to come back and re-biopsy you a year later for your confirmatory biopsy. Well, patients were refusing to undergo a second biopsy to face those risks. So I felt that there was only one solution, and the solution was to go back to the perineum. The perineum was the perfect pathway. It's a sterile pathway. We avoid all the fecal contaminants, and we can sample the entire prostate. So in 2011, that's when the urologic community woke up to this reality. That's when all the publications started circulating, showing that hospitalization rates after a prostate biopsy were doubling and tripling, and the overall sepsis rate ranged from 1% to about 6%. And the mean sepsis rate was about 2%. You might say, well, that's pretty low, but imagine you're a woman having a breast biopsy. Imagine if you told the woman that's having a breast biopsy that there's a 2% chance they will wind up in the hospital with life-threatening sepsis. And there's two ways we could do it. We could do it one way that completely eliminates that risk, or we could just do it the old-fashioned way and you could face that risk. I have a strong suspicion that the advocates for breast cancer would not tolerate the technique that would put them at that risk. In fact, even at the Maryland VA, we had 2 deaths from a prostate biopsy in 1 year. I mean, 2 men died unnecessarily from this. So, I mean, it's a real problem and we just needed to deal with it. And my solution was, and my passion was, I'm going to reintroduce the Transperineal approach, but I'm going to make the Transperineal approach something that is user-friendly, something that can be duplicated worldwide and use similar resources as a transrectal biopsy, easily trainable, easily convertible, and also done under local anesthesia, just like a transrectal biopsy. Now, the idea of a transperineal biopsy is actually not necessarily new. As I told you, back in the 20s, we were going through the perineum. In 2001, urologists primarily in Europe, they took the brachytherapy grid that we use to put radiation seeds into a prostate, and they thought, well, we're going to go back through the perineum, but we're going to use the brachytherapy system, and we're just going to slide our biopsy needle through one of the various apertures into the prostate. And that was called the transperineal saturation biopsy. So you'd basically, if the prostate sat over the grid plate right over where I'm drawing with my cursor, you would just biopsy through every aperture coming across in rows and columns. Unfortunately, the patient is going to get poked 30 to 50 times. And the problem with the grid is it forces your biopsy needle to only go in one direction. You don't have the ability to maneuver complicated motions because the prostate's not a box. It's actually more the shape of a pear. So in order to properly biopsy the prostate, you need to introduce your biopsy needle at complicated angles. And I knew that the grid could not accomplish this. Again, it was 2001. Here's another view of the whole procedure. There were just a lot of bugaboos with this transperineal approach. I actually have never done a prostate biopsy using the grid stepper. There are still people using this technique. They're quickly adopting our methodology because it avoids a lot of the problems with this. You can see the patient is put in this exaggerated dorsal lithotomy position. They've got this very rigid instrument with the probe into their anatomy. And the patient, to tolerate this procedure, has to be put under deep anesthesia. And it takes about an hour of operative time to move from one patient to the next. So, I mean, many urologists are doing 20 to 40 biopsies a month. You know, it's just not feasible to do the biopsy in this fashion. However, here's the positives. This is a meta-analysis of every publication up to 2013 that did a transperineal biopsy with this technique. And the real positive was that they nearly eliminated sepsis completely. This is a meta-analysis of all these manuscripts. There was over 6,600 patients, and there were only 5 cases of sepsis, which is quite encouraging. That's a percentage sepsis rate of 0.007, which is quite low. And then the same literature review found the infection rate with transrectal to be 5%. This was done by Jeremy Grummett, who's a very respected urologist in Australia. Just to show you the schematic, because we had this infection issue, and now we have the issue of diagnosis. So if you look at the schematic to the left, the transperineal approach introduces the biopsy needle right in line with the zonal anatomy. So you're able to come up into the anterior prostate or the apical prostate over here very, very easily, just straight on. And to the diagram to the right on the screen shows the transrectal trajectory, and you're very limited. Your angle of entry is a little bit obtuse, and you're not able to thoroughly sample each zone of the prostate. In addition, to get up to the anterior and apical regions of the prostate takes a little bit of special attention. And again, you're not flying into that zone. You guys are aviators, so I can definitely talk a lot about a lot of aviation terms that I use to train patients. We fly in and we get a full representation of that region of the prostate versus the transrectal, which are just merely poking up at the prostate. This is actual real data from Johns Hopkins, and it shows MRI images of hundreds of men that had positive MRIs. That's to the left. And so the darker the blue is, the more concentrated the cancer exists in those areas of the prostate. So you can see it's fairly representative throughout the entire prostate, except for the anterior base where we don't find much cancer at all. If you look at the heat map to the right, this heat map shows with the transrectal biopsy where it misses all the cancer. And you can see the cancers that are missed are all up here anterior and also on the apex. These are the areas that I knew I could more accurately sample. And that was the second benefit of going transperineal. Again, to highlight some of the issues with the grid stepper, the other problem with prior transperineal approaches is that many of these patients suffer other complications that we don't see with transrectal. For example, up to a quarter of the patients will not be able to pee properly for the first few days after the biopsy that way. There's a lot more perineal pain because imagine 50 pokes through all the anatomy to get to the prostate, and a lot of rectal pain, including erectile dysfunction of up to a quarter of the patients. Not necessarily permanent erectile dysfunction, it may be transient, but it's still equally bothersome to the patient. So the main reason that I felt that we needed to move away from that transperineal approach was, again, general anesthesia is just not necessary. An hour for a biopsy is a bit excessive. All the additional costs of anesthesia and the staffing. The brachytherapy apparatus is very expensive. It's very fussy and requires a lot of adjustments. It can't be performed in the office. It's just a complicated and bogged down approach. And since we're now using MRI, we needed to have something that could more accurately use the MRI in conjunction with the biopsy. And after basically about 4 years of hard work, research, and working on commercializing an actual device that accomplished this, we came up with the PrecisionPoint Transperineal access system. It's a fairly simple looking device. There's lots of features in the device that make all of these goals realistic to the urologist. So we have an adjustable clamp so that urologists don't have to buy new equipment. They could just clamp it on probes of various diameters or shapes. We have all these special features, cantilevered stabilization bars. We've got a proprietary access trocar and multiple aperture settings. With this device, we're able to accomplish the sampling that you see with the grid stepper apparatus, but only through 2 punctures in the patient's anatomy. So this introducing trocar enters the patient's perineum on the right, and then through that single puncture, we're able to manipulate the probe and the XYZ axis and enter different zones of the right prostate through that one puncture. Once we're done with the right prostate, we disengage the carriage, spin over to the contralateral side, one puncture, and sample the entire left side of the prostate. The device has also been validated through the FDA in conjunction with MRI fusion platform. So we can take the MRI images from the patient, import it directly into our software, and then using the device, we can fly right into the region of interest found on the MRI. The data is emerging. There's about 12 publications already published worldwide using the PrecisionPoint method. And just to highlight some of the real nice milestones that we've achieved, you'll see in all the trials that the sepsis rates are essentially zero. We're showing cancer detection rates that range from 70% up to 79%, which when I was doing transrectal, our average cancer diagnosis was about 38%. So we really, by being able to sample so much more thorough and the entire prostate, we're able to capture, all the relevant regions where cancer may hide. And not only is it just about diagnosing any cancer, we're really most interested in the clinically significant cancers, those that are not the slow growing variety. And we detect, anywhere between 50 and 60% of these cancers are found to be clinically significant. I decided to just give you this very, high level overview. And if anybody had questions or comments, I'd be happy to address it. Our website has videos. I didn't know really if we really wanted to show you live videos. Sometimes people may react differently to that, but certainly if you go on perineologic.com, you can go under, videos and see exactly how the procedure is done. I'm proud to say I trained a urologist today who is a U.S. Army veteran. He was an Army urologist who worked at Fort Hood for 10 years. And now he entered private practice right outside of DC. We're hoping to use his connections in the military hospitals to further improve our visibility, because most urologists will admit, they didn't admit this 7 years ago when I started the project, but now most urologists are willing to accept the reality that, the transrectal is rotting on the vine and the transperineal approach is taking front and center and will become the new standard of care.
Matt, I have a question for you. What kind of anesthesia do you give for this procedure now? Is it just twilight, or you just do local, or what do you do?
Yeah, actually, the real benefit and the reason we've gained tremendous traction, for example, in the United Kingdom, year to date, 75% of all prostate biopsies are now done with the PrecisionPoint. And why has it exploded to that degree there? It's because they were definitely believing that transperineal was the answer. And in fact, they started the movement called Trexit, transrectal exit, in comparison to tongue-in-cheek Brexit. And their goal was eliminate the transrectal biopsy completely, but they only had the grid stepper, and they were tying up their OR all day long doing a small amount of biopsies. We presented our solution, which is done under local anesthesia, and they were able to transfer all that care into the outpatient clinic. Now, having said that, I still believe that about 85% of men are happy to go through this experience under local anesthesia. I also will admit that about 10 to 15% of patients would be better served with twilight. Now, this is not general anesthesia. This is kind of like going for a colonoscopy where you just have an IV in and they inject a little bit of propofol. So it's very, very light anesthesia, and we combine that with local.
Guys on active surveillance, what are you recommending for number of biopsies, and what is how often are they going in there and that kind of stuff?
Yeah, well, when we started active surveillance, I started doing active surveillance about 11 years ago. I was a pretty early adopter because I feel very strongly that, we should not be treating slow growing prostate cancers. But I do differ from some of my colleagues. Not all slow growing prostate cancers are the same. Some you'll pick up like one core with a couple millimeters of Gleason 6. And then another patient I'll diagnose, I'll find, 8 cores fully loaded with Gleason 6. Those two patients are going to have a very different path forward. We do know that, if you follow a guy with very low risk disease for 10 or 15 years, there's probably a 15% up to a 30% chance that it's going to progress. So if you pick up a patient who's got 8 cores of loaded with Gleason 6 and the next patient with just a crumb, you're picking up the guy with more volume. He's probably had that disease for 6-7 years. So that patient, I might treat slightly different in my surveillance protocol. I would tell them that I'm going to maintain him on surveillance, but there's becoming the odds, the longer you live, the healthier your life goes, we might have to adapt the protocol slightly. On the other hand, the patient with just a crumb of Gleason 6, I might do 1 second biopsy a year later called the confirmatory biopsy. And if that looks similar to the first, I'm not going to touch that patient for at least 5 years.
Okay.
So there's a little bit of variability, but we definitely have pulled back on the repeat biopsies quite a bit. We used to do it every year, and that became, very frustrating for the patient and the doctor. The other problem was that, when I was diagnosing men, 10 years ago, I thought they had low risk disease because I was only biopsying the posterior half. There were no MRIs then. And it turned out that some men did very poorly because we were missing the relevant cancer that we never even touched. We just picked up a second cancer that happened to be low risk. So now with good whole gland sampling, we're identifying and classifying the men more accurately from the very beginning.
How are you integrating these new technologies like the Exosome DX and MDX type of tests and diagnosis tools and that sort of thing in with your the biopsy?
Yeah, most of the tests like the urinary exosome, the 4K score, the PHI, I'm now actually introducing the ISO PSA, and I will give it, a strong recommendation to our guests. ISO PSA. It was developed in conjunction with the Cleveland Clinic. It's basically like, imagine you have your PSA, okay, and your urologist comes and says your PSA is 6. That's your total PSA. If you could only filter that PSA, just filter out the PSA that's being produced by benign tissue and only filter out the PSA produced by relevant cancer, that's closer to what the ISO PSA is doing. Some of your other tests like the urinary exosome and the 4K score, some of those tests do require a little bit more clinical information to go into the algorithm. So I have used them in the past, but I'm now shifting my attention to ISO PSA because one of the problems I had with the urinary exosome, it can be a very good test. And I like it because it's a urine-based test too. Patient can do it right at home. But I had so many men coming back with the results being in the gray zone. It would be like 12, 14%. If it's high, if it's really high on the urinary exosome, it's super helpful. If it's super low, like 5%, it's also very helpful. The problem is if you have a lot of the guys coming in the gray zone, 12 to 14%, then you feel like you're back where you started. So I keep searching for a better secondary test. Now, all these tests are only indicated for men. You don't want to do it as like you replace your PSA with one of these every year. It's one of those things that you do, only a couple times likely in a man's career. And plus they're not been validated that well in active surveillance protocols. That would be very nice. So we could actually have a better blood test for men on active surveillance. Because right now we still depend on the PSA when we're not doing biopsies, and PSAs they can wobble all over the place. It becomes the bane of our existence.
Yeah. I know there's some new technologies, and I think later in the year, we've got some guys coming on from Mir Scientific that'll talk about what they're doing and their diagnostics tools and that kind of thing as well. So hopefully it'll be more of a liquid biopsy, which I don't think we'll ever get away from the true biopsy because, I don't think the pathologist would allow it, but right. I mean, they've got to get their CPT code in there as well. So but I think it hopefully it'll help give us some more I guess, definitive diagnosis in there, that kind of thing.
You know,
I guess
and
that,
I would
go ahead.
conclude too, Mike, I would say that, you know, even though PSA is somewhat limiting, you know, it just lacks specificity, but we don't have a blood test for women for breast cancer. You know, we don't have it for colon cancer. We don't have it for pancreatic cancer. So even though PSA, I mean, it, you know, begrudgingly, it creates a lot of problems. At least we've got something that's easily accessible, but we should be doing smart screening. You know, the day of just screening men with PSA and the moment you're over 4.0, you automatic biopsy and automatic treatment, all that, those days are so far behind us. Amen to that. We now are looking at the new generation of smart screening, and you're exactly right. Liquid biopsy, better blood-based tests, better urine tests, but it takes years for a lot of these things to get validated. So we've got to use the tools we have now very well. We can't say, I'm just going to sit on my hands and wait for the perfect liquid biopsy, because I'll be honest, I don't think it's going to happen in most of our panel's life or our relevant life, you know, at this point.
How many do you have? I know, I think Kelly does, but do you have is there a listing on your site or anywhere that tells the patient or tells guys where they can, you know, what urologists are using the PrecisionPoint system and doing the?
Yeah, we've actually toyed around with a couple different ideas. We started out with a physician locator. So basically everybody that we trained was on the website, and you could just plug in your zip code and bam, there you are. The problem is that we found that sometimes people wound up searching and they just weren't getting connected properly with the doctors. So now we have our staff, our crew, on the website. You can email us directly and say, I'm, you know, Mr. Smith. I live in Portland, Oregon. I want, you know, and then you can give us a little bit of background. Are you an active surveillance patient? Are you just wondering if you should even get a biopsy? And then my team will give me that email and I'll look it through and I'll chat with you personally and say, I'll tell you what, I think based on your needs, you might want to just stay right there in Portland. And we've got 5 urologists that are trained. Or I might say, you know what, I think you should drive down to San Francisco and go visit, you know, Dr. Shinohara, who does this and this, but also uses a transperineal approach. So we're actually decided to just hold the hand of the patient a little bit more to make sure they made the connection and that everything went well. I typically will follow up and make sure that everything went smooth, because everybody that we train, we want to maintain, you know, these standards. Like everybody needs to be doing it the right way to get the right results and no problems. And I want to make sure if I send Joe Gallo to some urologist in Portland, that I call Joe and say, how did it go? He goes, oh my gosh, it was perfect. They treated me with respect. It was an easy experience. I really enjoyed it. So either option, but yes, we've got.
Hey, Matt.
Yes, Joe.
I did have your procedure, but I didn't have it in Portland. I had it over in Philly.
Oh, did you? Oh, who was your urologist, if you wouldn't mind?
Andres Correa at Fox Chase.
Oh, wait, I'm sorry.
My daughter. Yeah.
Who was it again, Joe?
Correa at Fox Chase.
Oh, great. Yes.
Andres.
Okay.
Yeah, and I can give you a little bit of an endorsement with it because I had, up to that time, I had 2 biopsies and 3 MRIs, and all the time it kept up with low concentration of Gleason 6. Okay, actually 3 cores, and when we had the procedure done, we did it in conjunction with the micro ultrasound. All of a sudden, we got to a different part of my prostate, and I ended up with a Gleason 8 that became a 9.
Oh, shoot. I'm sorry, Joe.
So it was well, you know, the good and the news and the bad news. The bad news is that I got the bad Gleason. The good news is we found it. Okay, and that was because we used that procedure. And I know that Mike had asked, you know, what does it feel like? I had the 2 local injections, and that was it, you know, and after that, there was nothing except getting used to being in a slightly different position.
Yes, it
Yeah.
is. It is the birthing position, if you will. And, actually, we thought that that position would be less tolerated than the laying on the side, but they did a really great study in South Korea, and they randomized the patient to both positions. And actually, the tolerability turned out to be better dorsal lithotomy than on the side. And I don't know exactly why, but we're constantly adding little layers of improvement onto the biopsy to make it more tolerable. In fact, today I just introduced using an ointment that's rubbed near the anal sphincter that actually causes all that muscle tissue to kind of go floppy and relax, so that even the introduction of the probe is not so uncomfortable. So I'm concerned about every aspect. In fact, I've tried to biopsy myself, but it's just really hard, like actually I would happily undergo the biopsy. I wanted to do it at the AUA the first year we launched. I was going to eat a sandwich and have somebody biopsy me, awake and just eating a sandwich. But, the AUA didn't like that idea.
Yeah, right. Yeah, too much. It's an interesting topic. I just was at CR Space in Washington, D.C., and we were handing out materials and literature to guys, focusing on the veteran population, right? Most of the people showing up there were vets. And I would say that 90% of the questions I got were guys worried about their biopsy. And I, as Matt, as you well know, I was sending Evan and John emails every day. Guys are having questions about biopsies and how do we, what's the best way to do it? Why should I do it? How do you do it? What are the results? What, does it hurt? Does it not? So I think that as we look at this, look at prostate cancer, the number one, I think, impediment to prostate or guys getting their, prostates checked is the biopsies, the fear of the biopsy, right? And it's a big issue. And I think that we've got to do a better job of getting the word out. The other question I had for you is how many of these systems have you moved into the VA?
Kelly, what would you say our count is? Kelly's with me and she's been observing and taking notes.
Oh, good.
It's growing nicely. We're approved at the military hospitals and the VA hospitals. The problem is getting the training because we want to make sure everybody's trained right. And then there was some issues getting the right ultrasound probe because we prefer a probe that's not standard for transrectal. But now we've introduced training using the old-fashioned transrectal probe, which our device works on quite nicely. So now we've introduced that. That's going to help move it faster. And Kelly's going to try to get a count on this.
Okay, I was just curious. I mean, since I don't see them on, usually Jeff Jones is here and Mohammed Siddiqui is usually here as well. Some of those urologists, and we're trying to push it around. Isla Garraway was here last time out in UCLA and West LA. So they're usually on. I didn't know if any of them were using it. I don't know if Jeff's using it or not, but we'll definitely drag them. I know they're all going to be at AUA, so you'll have a time to chat with them about it there.
Yeah, Dr. Siddiqui, he's been fabulous. He's
a great guy.
I trained him a couple of years ago. It's taken a couple of years to get the VA going. He's got that running in Baltimore, and now he's brought it into the university campus. We try to do the VA hospitals that are overseen by the universities so that we can really ensure like the highest quality, applier to the technique. I just see that the sepsis rate, all the numbers that I quote on complications, unfortunately at the VA hospital, you almost have to multiply it times 2. And that should not happen.
Yeah. What can we do and how can we as an organization help you? I mean, the guys are here on the call. What materials and what do you recommend that we can do when we go and see our local urologists and our local hospitals and the VA and that sort of thing?
I mean, we really believe that, and there's a great example of this in Australia. The Medicare of Australia has, because of patients, decided to cut the payment to transrectal biopsy 50% and increase the payment to Transperineal by 30% because, a lot of urologists are like, boy, I might have to buy some new equipment. I got to go back to school. I got to learn a new technique. Why should I do this? there has to be some motivating factor, but in the VA and the military hospitals, that's not the issue.
Yeah.
The issue is just to voice your opinion and say, isn't there a better way to do the biopsy? Isn't there a safer, smoother, better result technique?
Yeah.
And once the patients start talking about it, the urologists say, you know, I got to do it. I didn't want to go to school and learn this new one, but I got to do it. So really your voices mean more than everything.
Okay. We will, that, and I think we find a lot of good traction when we actually hand these guys like just a single 5x7 sheet or something about hair, you know, hand it to the doctor and say, I want you to, this is what I want, right? I don't want to, you know, it's kind of like with me and Xtandi or whatever. You hand them the Xtandi brochure and you say, this is what I think I need, Mr. Oncologist, right? And I'm on this stuff. And so, you know, why shouldn't I have this? And then, or what is it? You have that discussion with the doctor right there, you know, on site. And I think it would be, that's something I think we should look at, is maybe helping you or doing a co-production of some materials to hand out to these urologists when we go and see them, right? So that they have something to leave behind.
We'd love to hear from all of you on what we can do better too. We're learning as we go along. What's the best, most efficient pathway? So Kelly, 11 military or VA hospitals currently, which is small, but it's growing quickly.
That's good. No, that's good. You need one, because then we can use that as evidence and basically ammunition to say, hey, it's already being used in the VA, so why don't you guys have one? So you better get it. And let's get on with it.
I will tell you one thing, and you alerted us that there was this chunk of money that was set aside for the veterans, so they didn't have to necessarily travel from the VA clinic to a VA hospital to get certain urology services.
Yeah.
I put the word out to our VA clinic, and I've been inundated with all these wonderful vets who their only insurance is through the VA. And now they can come in and I can do everything that I do. And they're so happy. I can't even tell you how rewarding it is. They come right in my community. And this is a program that could be applied all over the US. And thank you for sharing, because even the head doc at the VA clinic, he didn't even know about it. He looked into it, he's like, you're right. And all of a sudden, like, I was able to start caring for these men instead of having them drive 2.5 hours away to get a transrectal biopsy.
Yeah, that he's talking about the community care network, and it's something that we try to talk to our, to good doctors like yourself and to good practices that actually can then know the importance of actually the follow-up. And I heard that we're having an issue in the radiation oncology side that we are going to try to address later this year. But it's really important that the doctors back at the VA who are going to continue that patient's care and then deal with all of his other comorbidities have those treatment records, right? I mean, it's not that hard to give them the records back, right? Just tell them what you did and what the procedures were. This is kind of sort of makes sense, but a lot of times that's the biggest complaint that we get from the VA physicians is that community care physicians or guys that are using this service out in the community are not given back the full treatment records. And that sometimes becomes a problem, or they got to chase them down or do whatever. But that's why the leadership of the VA has asked us to make sure that we do our due diligence. And this kind of goes to everybody in the crowd. Don't recommend community care to a physician that you wouldn't want to go see yourself. Okay. I mean, that's a good litmus test, right? Make sure that you would want to go into that guy's office before you ask him to sign up for community care. All right. Because it is important that that whole continuity of care back to the patient, especially if you're in the later stages of cancer care and that sort of stuff. It becomes pretty critical. I don't know, anybody else questions for Dr. Allaway? Well, we got him on the phone. Well, I appreciate. Oh, hi, Marianne.
Sorry, I just had a thought. The one pager is designed for both providers as well as for patients. I think, like, if you wed something like that with information about something that's a little bit less painful and less invasive, that might be an approach, right? So you don't have to recreate anything.
Sure.
And then
I agree. And I think it's I think we need to do something like that. We need to have something available that's out there.
Well, you have it already. I mean, I know you did it in conjunction with Zero, so that's a thought. And then Dr. Allaway, I mean, thank you for presenting this. I guess just from a question perspective and thinking about screening coverage. And I think about some of the liquid biopsy tests that are coming online from like places like Grail with the Gallery screening test. And I think about the reimbursement then and that impact on patients' out-of-pocket costs, because if we start seeing these screening tests have sort of like an uptick, then to go and get a second procedure, there's like a coverage issue. And so that's just something I would plant a seed for future discussions and as a thought. I don't know if you're seeing any sort of implication like that. And I'm thinking about the US marketplace.
Yeah, I mean, it's a zero-sum game, you know, it's a pie. And if you start introducing lots of new testing, you know, then, you know, they have to try to move money around to justify the payment for these. Oftentimes the patient's straddled with the cost of these things. So when you talk about like genomic testing, for example, after you have a biopsy, you can send the tissue off to have genomic test done on it. And, you know, there can be benefits to this, but that's a $6,000 test.
Yeah.
And a lot of insurance companies won't cover it. And, you know, we've got to be very smart as urologists to look at all the different options and try to think about it like, what's the most efficient use of the very best test? Sometimes when you inundate with too many tests, then everything becomes blurry and you're like, my goodness, I feel like I'm back at the starting point again. So, you know, as a medical device company, I'll tell you, we have a much more of a higher slope to get to our plateau than lab tests and drugs. And so we often don't see a lot of the benefits. Lab tests sometimes come through with these exorbitant payments, and sometimes they're just not validated over time. So we need to be cautious. And but it's happening at a rapid pace. So it's an exciting time too. It's a good time to be a man, you know, looking at screening, because there are many more tools in our box to work with.
Yeah. And thanks for that. I was going to ask a quick question about the CPT codes. Is biopsy a biopsy regardless of whether it's transperineal or transrectal?
It kind of depends a little bit on the setting you're getting the biopsy. You know, there is a transperineal code that was developed based on the grid stepper approach. There's also the existing transrectal code. So the good thing about our technique is there are codes to use. I mean, we fit into it from either side of things, depending on the place of service. Granted, one of the issues we face is just that, you know, I mean, when I train the urologist today, well, it's going to probably take them 20 cases to get up to a speed level where it's going to match how we can do a transrectal biopsy. But I would argue, you know, it's about quality. If we're screening men smarter, we don't have to do as many biopsies. We need to be a little bit more selective and just do a better job like Joe had. I mean, my goodness, I mean, if he could still be thinking he had low risk disease, but with a proper biopsy, suddenly it's like, this is what you really have. That's what we need to do on the first biopsy.
Yeah. Just so everybody knows, there is no charge in the VA for biopsies, right? So there's and by pushing this thing through, and then they're also, I'll throw my pitch in there for the DNA sequencing. There is a policy right now in the VA that if you have any stage, if you're diagnosed with any stage of prostate cancer, you should be having both genomic and somatic DNA sequencing done. That program, it's a study, it's run by our chief of our medical advisory committee, Dr. Reddig, and anybody that has any stage of prostate cancer diagnosed is eligible for that full DNA sequencing. And you should be able to ask your urologist or the oncologist that you're seeing to have it done, and call them if for you guys on the call. We'll have access to Dr. Reddig. So if there's a question that you get pushback from anybody in your VA facility, we'll get him on the phone and he'll give you the study. I've watched him do it before, heard him do it. He'll give the physician the actual study and tell him exactly where to go and how to reference it and how to get to it through the EMR system in the VA. So it's a good program to take advantage of it.
Excellent.
Anybody else? Thanks, Marianne. Well, I appreciate it. We're up to our hour. I think we're done with biopsies. We did talk about a little bit of the MRI fusion issue. I would encourage everybody to push that as well. I mean, we do need to push on the MRI aspect of things, because I think you can see things better when you're doing that. I think that's it. Also, after your biopsies, and if they come back positive, we're trying to push. The next step is look at PSMA imaging. It's available in all of the VAs now, so I think you can count on that being available. So talk to your urologist about those things as well. Anything else? I think if not, I want to thank Dr. Allaway and all of Perineologic. I think it's great. This has been very insightful for all of our guys, and everybody take the word in. You can go to their website. It's a great website to see how it works and what the material is there. It was on your invite, and it's on our site as well. You can get to their site from our website as well. So take a look at it. And we look forward to seeing everybody. That half of you will be on the call or will be at our reception in New Orleans. So we'll see you there. We're having a little party on the 12th. And I've got to call Terry. We need another bartender. So I'm going to enlist Terry to see if he can be a bartender. So anyway, so yeah, we'll have fun, and look forward to seeing everybody. And thank you for your participation tonight.
Thanks, Bing. And I also want to, I've got Evan Brazington, our CCO, and John Hart, our COO on the call, and Kelly's with me on the other side of the computer. We're all very committed to the movement with our veterans, and thanks for this opportunity.
Well, I appreciate it. Yeah, thanks, guys. Thanks for volunteering and for your support. And yeah, we're seeing that. I mean, as you saw, I mean, everywhere we go, everybody has a question about biopsies, and I appreciate you guys answering all those vets calls that were coming in trying to find out where they could go to get it done. So
yeah, thanks for sending the info over. I appreciate it.
Yeah, no problem, man.
And we apologize for our dog. It's the time of the evening where all the deer come out to eat, so she gets a little bit rambunctious.
That's all right. Keeps us all awake.
All right.
My dog was happy to hear her too.
Yeah, there you go.
One question.
Yes, sir.
Yeah, Terry.
Yes.
Are we going to have access to the recording of tonight's session, including
Yes,
the
sir.
slides?
Yes, you will.
Okay,
And,
great. I'd
we'll
like to pass
distribute
those
them
on.
Yeah, we'll pass them on to everybody that was invited, and you'll have access to the digital recording of the call. And then you've sent that on, Terry,
Thanks.
to your 170 guys or whatever, 175 guys. We've had a couple people call in from your group asking some questions too.
Oh, good. Yeah, I've got a little over 200 now. So yeah, I would pass that on to them.
Awesome.
Great.
All right.
And I'll just add to that, and Terry, just to add to that, this recording will also be going on our website. So we'll be starting to curate all of our meetings on the website as well. So
Okay.
you don't have to worry about sending out email links. And then we've also created a private Facebook community for 50 vets in 50 states, so we can be able to continue the communication in between. Recordings will also be on that. We will definitely open it up to our presenters and medical professionals as well, that they can chime in. So if you have questions, that's a great place to start to curate that.
Yeah.
Great, thanks.
Okay. I think that's it. I think it's a wrap. Thank you, everybody. Appreciate it. And we'll see you next month, same time.
Hey,
Thanks, Mike.
thanks, everyone.
See ya.
Thanks. Bye.